Hi, this is Mark Purdue, and you're watching EKG video tutorial 10.0 on devices. In this video, we're briefly going to review the electrocardiographic appearance of cardiac pacemakers and then the role of internal cardiac defibrillation in the management of ventricular arrhythmia. If you think back to the 3.0 series in which we studied chronotropic incompetence, that is to say, the heart's inability to generate enough effective ventricular contractions to sustain cardiac output. That is to say, we have to have an LV that's squeezing a sufficient amount, but also we have to have the appropriate number of squeezes or beats per minute. If the beats per minute, depending on the patient's overall health, ejection fraction, etc., goes down below 40, we're definitely going to have problems and even higher heart rates for other patients. Now, the sources of chronotropic incompetence usually come from two places: the sinus node, whether it's sick sinus syndrome or some other medication or external cause that is causing insufficiency of the sinus node, or the AV node, whether it's some high-degree heart block that's been caused by ischemic heart disease or whatever. Regardless of the source of the problem, if there are not sufficient beats per minute, the patient will not be able to sustain cardiac output, which is going to result in symptoms like complete syncope or even death if this goes on for a sustained period of time. We will require some source of external pacing to maintain cardiac output. This, of course, brings us to the implanted cardiac pacemaker. If a patient's heart on its own won't make enough beats per minute, then we're going to put a device in there generated by a battery source that is going to help the heart to generate sufficient beats per minute. It consists of a generator, which is a small, about the size of a Zippo lighter or a small stack of credit cards, and it is placed usually in the subcutaneous tissue in the upper left chest. The leads come out of the generator and then are placed into, for example, here the right ventricle or wherever there is going to be a need for a pacing spike. You can see on the left we have a chest x-ray, and it's showing you the generator, the appropriate position of the leads. And so sometimes you'll have a patient with a pacemaker, you'll get a PA chest, and it'll look something like this. For the most part, you just want to make sure that it appears that the leads are connected to the generator and that the leads are somewhere in the heart and haven't migrated somewhere else. If we have a patient with straight sinus node dysfunction, we may see something like a single chamber pacemaker. Here we can see that we have an atrial pacer spike, depolarization of the atria as evidenced by a P wave, a QRS complex, and then kind of this funky inverted T wave. Now, I don't see single chamber pacemakers as frequently as I see dual chamber pacemakers. If we have a patient with mixed chronotropic dysfunction, or if we have a patient with AV node dysfunction, it's going to be important to pace both the atria, as evidenced by this initial spike, and the ventricles, as evidenced by this pacer spike. And by doing that, we can synchronize the atrial and ventricular contractions. By doing so, we can synchronize the atrial and ventricular contractions. Now, there are a number of ways in which the sensing and pacing functions of these pacemakers can be configured to meet the electrophysiologic needs of the patient. Now, biventricular pacing is different altogether. Patients that need biventricular pacemaking are not having problems with chronotropic incompetence. They have enough beats per minute. Their problem is that they have underlying heart failure and then some kind of intraventricular conduction delay, whether it be a left bundle branch block or whatever. They are not getting synchronization of the ventricular contractions, and this is reducing the efficiency and subsequent cardiac output. To remedy this, they deploy biventricular pacing, and then in doing so, they can improve the efficiency with which the ventricles are synchronized and therefore improve cardiac output. Pacemaker malfunction is thankfully rare, but occasionally it does happen. You can see in the upper right-hand corner, we've got a pacemaker malfunction, failure to pace, and the patient's thrown right back into type 2 second-degree AV block with a relative bradycardia. Over here, we can see essentially the functional equivalent of third-degree heart block. We have atrial and ventricular pacer spikes, but they have nothing to do with the underlying QRSs. It's not clear if this is a result of a broken pacemaker lead or if the battery died or whatever, but these patients may require some form of external pacing until we can get the patient to cardiology, specifically electrophysiology, to remedy the problem by reprogramming or fixing the pacemaker or whatever. Lastly, we have the internal cardiac defibrillator. Patients that are prone to ventricular fibrillation arrest or ventricular tachycardia of various forms will benefit from these types of devices. They are similar in size and structure to implanted cardiac pacemakers. You have a generator over here in the upper left hand, and then you have these leads with shock coils. And what's going to happen, you can see over here on this chest x-ray, the lead and then the coils being placed into the heart. Instead of generating a pacer spike for chronotropic insufficiency, these patients, of course, are going to go into high-rate ventricular tachycardias of various kinds. In panel A, we can see that the patient is going into V-tach, and instead of shocking the patient, it performs a pacing function. So it generates pacer spikes at a rate that are higher than the underlying ventricular tachycardia, thereby becoming the dominant pacemaker. After achieving the dominance as a pacemaker, it withdraws that impulse and allows the resumption for sinus rhythm. In panel B, we can see that the patient again is going into ventricular tachycardia, and instead of anti-tachycardia pacing, we're seeing cardioversion. This is a synchronized function where the computer identifies the precise point in the cardiac cycle of the arrhythmia for the deployment of a shock. This is a cardioversion shock, and you can see that the patient has resumed sinus rhythm. And then lastly, we have ventricular fibrillation. If the device senses that the patient is in VFib, then it simply delivers an unsynchronized shock, hopefully restoring sinus rhythm in the patient. The technology of these devices is always improving. Now, occasionally you can see a patient with an ICD will come into the emergency department and they're experiencing unnecessary shocks. It could be that the patient is in AFib or SVT and they've got a wide complex response. Whatever the problem is, if they're having unwarranted shocks, if you can identify that they're not having VFib or VTach, but they are getting shocked, you can place a magnet on the device, which usually every department has one, and then stop the sensing function of the device until you can contact electrophysiology and get that problem sorted out. So let's wrap up this EKG video tutorial. We have talked about the importance of EKG. It is essential to diagnose conditions like an ST segment elevation MI, crucial in the evaluation of acute coronary syndromes, and again, the only way that we can diagnose dangerous arrhythmias like the ones we've discussed in the course. EKGs can give us a very important clues about conditions like pericarditis. And if you have a patient with a pericardial effusion and they come in with electrical alternans, you can be pretty certain that they're heading for or are in tamponade. Again, a very important condition. It also can give us important clues about heart size in terms of atrial enlargement or left ventricular hypertrophy, and that can be a very important condition in terms of the patient's overall health and management. EKGs can give us clues about dangerous toxicities, particularly in the emergency department setting, but as well as electrolyte disturbances and even, as we have seen, in hypothermia. So there's quite a range of information that we can gain from electrocardiography, and I would suggest that EKGs are going to be with us for the next 100 years or the rest of our careers. So with that in mind, we want to become proficient in reading EKGs, and so I would just give you a little parting advice as we finish out this EKG tutorial. One, remember to do both a quick look and then the checklist mentality. Quick look is going to be when we initially look at the EKG, and especially after we acquire a lot of pattern recognition, we're going to be able to look at an EKG very quickly and see that they have an inferior MI or a wide complex tachycardia or a heart block or whatever. But after we have noted that important glaring abnormality, we need to go back and kind of do our raised right checklist. We need to make sure that we verify the rate, identify the rhythm, the axis, our three intervals. Importantly, we want to make sure and go back and then very intentionally look for ST and T wave abnormalities, and then consider electrolyte and environmental changes associated with EKGs, and then of course drug toxicities, and then of course devices in the form of internal cardiac pacemakers and defibrillators. Also remember the importance of the rights, and that's going to be the right patient in terms of having the patient's name and date of birth on every EKG, the time and date at which it was taken. We're going to write our interpretation on there, and if a computerized interpretation is listed, we can write something like agree and then sign that EKG. Make sure that if you're given an EKG and it's not of adequate quality because of wandering artifact or dirty baseline or whatever, insist that it be redone to standard, because it's going to be important for this to become a legal document and part of the chart. Also make sure and compare it with any previous EKG EKGs so that we can identify if the left bundle branch block is new or whatever. And then remember to clinically correlate some findings that you might come across. So if you have a patient that is 12 years old and they have inverted T waves in the anterior leads, that's probably okay for that patient, but it's probably not okay for an 80-year-old woman that is diabetic and experiencing chest pain. So make sure that your EKG interpretations match up appropriately with the patient's medical history, age, and so on. Also, there are specific EKG findings, and then there are not so specific EKG findings. For example, T-wave inversion in an adult patient. That could mean a number of different things, so you definitely want to formulate a differential diagnosis. So for example, if you have a patient that comes in with those deep downsloping ST segment depression with T-wave inversion, and their complaint was headache and loss of consciousness, you definitely want to consider an intracranial hemorrhage rather than presume that it's some kind of cardiac problem. So revisit differential diagnoses and make sure that your EKG interpretation matches the clinical setting of your patient. Next is consultation. Sometimes I'll look at an EKG and I feel like I know what it's saying, but I'll show it to a trusted colleague just so I can get a second set of eyes. Also, if you know someone that has been reading EKGs for years and has established and interpreting them, it's also helpful to show it to that person if you have questions. And then, of course, if the stakes are high and you really need to get a definitive read on an EKG, it is completely appropriate to call cardiology and either fax or computer send that EKG to them for a second interpretation. Next is continued training. Try to read every EKG you can get your hands on. There are a number of books, websites, Facebook pages, and Instagram accounts that are tailored to people with interest in EKGs. I think that's an excellent way to just see lots of EKGs, but you also want to try to get into trusted peer-reviewed sources and then just keep practicing your EKG interpretation. And then in terms of your CME activities, if there's a workshop for advanced EKG reading or something like that, that's an excellent opportunity to review what you know and then to learn some new patterns and skills in terms of EKG reading. This marks the end of the EKG video tutorials.